Thank you very much, Sarah. Reminds me of thinking, as we often have, that we know actually what patients want and think, but we actually don't. And by integrating them into the design process, we actually do a much better job of capturing the voice of the patient. So thank you for sharing this perspective, particularly on the elderly patient. Our next speaker is Pascale Carayon, who's a professor of the Department of Industrial and Systems Engineering and the Director of Center for Quality and Productivity Improvement at the University of Wisconsin. Her research belongs to the discipline of human factors engineering, and we're identifying a physical and organizational environment that will improve system performance and worker well-being. So this is exactly what we're talking about as well today. And more than 400 leaders and over 150 healthcare organizations in the U.S. and elsewhere have been trained in her model of work system and patient safety. Recognized author, very well known on 2 National Academy boards, the National Research Council, and a member of the Institute of Medicine. So welcome, Pascale. Thank you.
Thank you, Gary. Is that microphone on? Okay. I realized that we're on a good start because at least for every panel that we've had this morning, we had someone from Wisconsin. So I hope that, there you go. And I know Chris Zinski later on will be, you're from Wisconsin too. Okay, and as you can tell, my accent is also from Wisconsin. Really, now, yeah, after I'm going to tell you my main message, you can go to sleep or you can go pick up some coffee. But really, my main message is very much in line with what Sarah just talked about, is the importance of looking at the human aspects of scheduling. Scheduling is really a process that involves patients, families, caregivers, physicians, nurses, as well as a number of other healthcare workers, such as schedulers. And so I'm going to talk about them a little bit and what's their job like. And we're here really to try to convince you that in systems engineering, there is a subdiscipline that's called human factors engineering, and that can help you better design scheduling policies, procedures, and system. So I'm going to be talking about 2 different approaches to healthcare scheduling. One of them is thinking about the scheduling process, and I'm going to do that within the context of our SIPS model. And so the scheduling process is one of those processes along care processes, supply chain processes, HR processes. And in order to really optimize that process, you need to understand the system, the people, what they do, the physical and organizational environment, and the tools and technologies. And the second topic I'm going to try to address in my 10 minutes is thinking about patient health IT as a way of improving access and scheduling. But again, thinking that IT is part of that larger system is only one element. So let's talk about scheduling process. I want to introduce you to what is it like to be a scheduler. And I'm going to be talking about a person who does the scheduling in the checkout function. I'm not talking about grocery stores here. I'm talking about primary care clinic. In the context of a large project on care coordination and care management that we did with a large integrated healthcare system in central Pennsylvania, we actually had a chance to spend time in a couple of primary care clinics, including looking at the checkout process. So let's imagine, I'm not sure whether you can see it. This is exam room. You're a patient. You're coming out from that room. And, as human factors engineers, we look for Post-it notes and different artifacts. And so there is one right here that has 3 green arrows. It doesn't point to the bathroom. It actually points all the way to the end of that hallway. And so go up here, and you're going to see the hallway. And at the end of that hallway, there is the door. Finally, I'm the patient. I can get out of the clinic and go home and get on my thing. No, no, no. There is that little door here, and that little door takes you to the office of the scheduler. That's the checkout person. So that scheduler has a tremendous role in that process. You may wonder, I don't know, I mean, again, as human factors engineers, we really train at looking at those details. What do you think that mirror is? Well, it's really important for the scheduler to know who's coming down the hallway, because what happens is very often patients may just leave and not go through the checkout process. So once the patient is in the room with the scheduler, you've never seen such a small office. It's really tiny. So the patient sits here with a scheduler, and then they can go through that process of scheduling. So that's the reality of scheduling. And so really that interaction between the checkout person, the scheduler, and the patient is about, well, let's figure out a time where you can go get your x-ray or your lab test. So there's a lot of individual and cognitive information processing activities. But there is a lot more in that job of a scheduler. They also have huge social organizational functions. They know patients. They take that into account when working with a patient and coming up with a schedule. They know what's happening in the clinic in terms of staffing and whether there may be issues with scheduling for patients. So their role is a lot more than a formal role. There are a lot of other informal roles. And so it's really important for you who are going to provide recommendations for scheduling policies and procedures to think about if we're going to design those tools, those technologies that are going to help with scheduling, we need to make sure that we design tools that are usable and useful. And scheduling, again, is a lot more than just coming up with rules and applying rules. So let me move to the patient side of things and looking at health IT as a way of improving access. And one of the things that I read in the background material that was provided to us is the idea that we can provide better access by replacing face-to-face encounters, and I'm talking primary care here. So replacing face-to-face encounters with encounters that are technologically mediated encounters through the use of secure messaging, the use of e-forms, patients uploading information on their portal. Well, I don't think it's a substitution. Again, if you think about the system, the implementation of use of those technologies create new work. It redistributes work between patients, clinic staff, and clinicians. And it really requires for the healthcare system to reorganize their work and their workflow. We are in the last year of a project funded by AHRQ looking at those three technologies here, secure messaging, e-forms, and the use of patient portal to upload information. And we're doing that research in 6 primary care and 6 primary care and specialty clinics in Wisconsin and Alabama. And we're interested in understanding the impact of those technologies on the workflow of clinicians, clinic staff, and patients. So I'm going to focus on just secure messaging, and later on, if you want to hear more about the other 2 forms of technologies, I'd be happy to answer questions. By the way, that's what it looks like. I don't know how many of you use secure messaging. This is actually my secure messaging in my patient portal. After a number of clicks, then I get to that page where I can send a secure message. In the context of that project, we conducted semi-structured interviews with 38 clinicians, 12 clinic staff, and 27 patients. And we used our SIPS model to understand barriers and facilitators in their workflow related to the use of that technology. And these are the different dimensions of the work system as well as perceived outcomes. So I'm not going to go in details, but I hope that no one is colorblind in the room. I should know better as a human factors person. But the green bars hopefully. The green bars, the bars that are at the top, are facilitators. The red bars are obstacles. And the numbers is the number of people within each of these three groups that say something is a facilitator, green, or a barrier, red. Following me so far? So now when you look at the three graphs, you see a lot of greens in the patient side. You see kind of red and green on the clinic staff, and you see a lot more red and also some green on the clinician slide. And really what we're saying in that part of the data is patients tend to like it. And again, remember that data is limited because those are patients that actually use the technology. It doesn't include people who don't use the technology. So one of the actual negative impact reported by clinicians was impact on their workload, on the amount of things that they have to do, figuring out who's communicating with the patients, whether it's the triage nurse, their medical assistant, and a bunch of other system issues. And so it's really unclear whether providing that different technology is something that's going to reduce or potentially increase visits in the clinic. It might reduce the visits because now with a couple of messages you can solve a problem, so a visit is not scheduled or is postponed, but it might also increase visits. Suddenly the patient needs to come in. One of the things I just wanted to mention, the light is blinking, is the use of secure messaging to send reminders to patients about their upcoming appointment. Great, and what we've heard from the clinics is that actually reduced the number of no-shows, and I know there was a discussion about that earlier on about that. But think about that patient. What about if that patient doesn't speak English? The portals and the secure messaging technologies available to those clinics were only available in English. And so you might actually be creating what Sarah was talking about, the haves and the have-nots. And our results really fit nicely with two very recent systematic reviews looking at those technologies. And again, it's the yin and the yang of whose workflow are we improving and whose workflow are we not improving. So I really hope that we've convinced you to look at the human aspect of scheduling. And if we're going to design and improve scheduling policies, procedures, and technologies, we need to understand the system in which we're implementing those new systems. Thank you.